Well, thank you for joining us today. And stories like Jenny's are the reason why we are holding this forum. And Jenny is not alone in her experience. Fewer than 50% of rural women have access to perinatal services within a 30-minute drive of their home. And as a woman and as a mom, I can sympathize with her story. And today we have nearly 1,000 people participating in this event, both in person and online, and I know that many of you feel the same. And this topic hits particularly home for me. I experienced 2 dramatic births with both of my kids that required emergency medical attention. And I remember that drive to the hospital. It was only probably about 10 miles away, but it was a very, very long drive. And I swear my husband, God bless him, was driving under the speed limit that day. But I really think it kind of hits close to home because I know if there was a delay in me getting to the hospital, it may have really affected the outcomes for me and my children. Maternal health is a growing concern in this country, especially in rural America. The President, Secretary Azar, and the entire administration, such as CDC, the NIH, and HRSA, are all focused on this issue, and we're committed to improving maternal health outcomes. And the conversation really comes at an important time. Out of 157 countries that reported decreases in maternal mortality, the United States was not one of them. And to make matters worse, pregnancy-related deaths have almost doubled in the last 30 years. And the death rate is even higher for women that are living in rural areas and for women of color. And again, this is something that's concerning to me. I started my career actually working in maternal and child health in a public health department. And to think that we are decades later and that we haven't made improvements and some of the challenges have actually gotten worse are very concerning to me. And for women that are living in rural communities, it's very complicated by the fact that we've had a lot of rural hospital closures, and that's occurring in parallel to rising mortality rates. So obviously the needle is moving in the wrong direction. We've been focusing on a few areas in particular to try to help healthcare in rural communities. One of them is advancing telehealth. Over the last couple of years, the administration has focused on making sure that there's an unprecedented level of access to telehealth in our rural communities by increasing access and paying for telehealth services through the Medicare program. The other thing that we've been focused on is our rural hospitals. We've been very concerned about the high rate of closures and the very low operating margins that they have. We just put out a new proposal to address the wage index and how Medicare actually pays these hospitals, because we know that in rural areas they've been getting a lot lower reimbursement than their counterparts in urban areas, which has a big impact on access for people living in those communities. I'm very proud to say that President Trump and Secretary Azar have placed an unprecedented priority on improving health for people living in rural areas. And for the Medicaid program in particular, this is a big issue. Right now, the Medicaid program pays for half of the nation's births. And the way I look at the Medicaid program is we're not just here to finance health care, but we really want to make a difference in the lives of the people that we serve and actually improve their health outcomes. So we're not here to just pay the bills. We really want to make an improvement. One of the things that we've done with the Medicaid program under the Trump administration is we've released our first ever Medicaid Scorecard. We spend so much money in the Medicaid program. It is the #1 or #2 budget item for every state, and yet we aren't able to say, what are we getting for that investment? So one of the things that we've done is put out the first ever Medicaid Scorecard, and it actually identifies outcomes, health outcomes that we can evaluate states' progress on. And as part of that, there's actually very particular measures on maternity measures. We have about 12 measures that are related to elective and elective C-sections, pre- and postnatal care, and contraceptive care. The other thing that we've done is create a rural health strategy as part of our Rethinking Rural Health initiative across CMS. I can tell you that any time a policy comes in front of me, I ask the staff in our briefing papers to say, what is the impact going to be on rural communities? So everything that we are doing at CMS, we're thinking about how does this impact rural communities? And our goals are to ensure that rural Americans have access to high quality care. We want to support rural providers, not disadvantage them, and address the unique economics of providing health care in rural America. Make sure that we are reducing unnecessary regulatory burden to improve health and outcomes for Americans living in rural areas. So maternal morbidity and mortality will remain a top priority for CMS. And we know that there's a lot more work to be done, and we don't have all of the answers. We need the input of people like you that are in the field, working on the front lines. So our eyes and ears are open. We see your challenges, we hear your concerns, and together we want to chart a path forward to improve access and quality and outcomes in women's health. So thank you again for coming today, and we look forward to hearing your ideas as we develop our strategy going forward. I'd like to give a special thanks to some of our guests. We have Kellyanne Conway, who's a senior counselor to the president here today. We have Congresswoman Debbie Dingell of Michigan, and Dr. Dorothy Fink of the Office of the Assistant Secretary for Health, Dr. Barfield from the CDC, Mr. Tom Morris of HRSA, and my colleagues, Dr. Cara James and Dr. Marion Couch, who have been very instrumental in putting together this forum today. So really appreciate their help. And with that, I'm going to turn it over to Kellyanne Conway, a mother of 4, who has graciously taken time to join us for this important event. Thank you.
Thank you very much, Administrator Verma and Congressman Dingell, Dr. James, and everyone who's here in the room, and I understand being live streamed as well. I've been called many things, but Mother of 4 is actually my favorite thing to be called, so thank you for that. I'm so delighted to be here. I bring greetings from the President and the First Lady, the Vice President and the Second Lady, and our entire administration as we want to continue the conversation with you and work towards solutions to really bend the curve in the right direction of what has become a very alarming set of statistics in this country very recently. As the Administrator said, and I will repeat some of the same statistics, I think we didn't coordinate our remarks, but I always believe repetition and reiteration allows us all to hear it together and give it the kind of important consequence that it deserves. So among the developed nations, the United States of America is the only one that has not reported a decline in maternal mortality and in maternity and delivery-related injuries as well. So when we talk about maternal mortality, we should also not lose sight, of course, of those who, thank God, don't lose their lives from this, but at the same time do suffer injury. Compared to their own mothers, women today are 50% more likely to die during childbirth. That approximates about 700 per year now. And as the Administrator made clear, and as we all know and must work on together, that is intensified among women of color, women in rural communities, and I believe among our Native American mothers, they are twice as likely to die in childbirth than the average. Among our African American mothers, it's 150% above average. So the harrowing statistics are there. The solutions must follow quickly. I'd like to tell you a little bit about what we're doing in our administration and at the White House specifically as we work toward expanding the conversation away from health insurance, which is important, and back onto health care, which is the way most Americans regard any conversation about health care reform. Our ability to live safely, have gainful employment, housing, educational, and workforce development opportunities, access to nutritious food and medicines, and overall more holistic health care while we are expecting and delivering our babies, and even before, during, and after that, and certainly being mindful of all of the positive health outcomes that can be had if we all, of course, work together in the private and public sectors. The President convened a Rural Prosperity Task Force. This is meant to bring together rural communities and best practices on any range of issues, including health delivery services. But it also is about workforce development. As part of that task force and working with the FCC, we have invested a $20 billion plan into rural broadband and other infrastructure like matters that allow us to work with the Universal Service Fund's Rural Health Care program and expand our telemedicine reach as well. We look at that as a very big step forward in working in a bipartisan fashion in this regard to allowing women more information and access to medical information and services remotely before, as was the case with Jenny and many others, taking those long and sometimes arduous treks to the closest hospitals in their areas. This also is a big step forward in us trying to bend the curve in the right direction on something I work on every day in the White House, which is the opioid and drug demand, drug supply crisis. And I'd like to take just a moment, since I know that there are many reasons that we are experiencing a surge upward in maternal mortality. But in terms of maternal health, we also are all aware that for some of these women, they are experiencing, as they are pregnant, delivering, and new moms, they are experiencing the stigma and the silence that often attends to substance use disorder and drug addiction and chemical dependency. We are trying to make them more comfortable to come forward and to admit either to their OBGYNs or other people in their circle of life that they may be tackling this challenge as well while they are pregnant, while they are preparing to become moms for the first time or again. And we don't want them to be alone. We don't want them to be disrespected and under-resourced. So this ends up being a very large piece of our opioid and drug demand work, because we know about 1 in 100 babies born every day in this country are already chemically dependent. That's about 1 in 150 to 160 per day, and it's probably an underreported statistic. We don't yet have all the longitudinal data as a country that we would like to have about the development of these babies longer term. I've personally met some 7, 8, 9, 12-year-olds and happy to report they're perfectly healthy and they're in school and they're growing developmentally according to their doctors. But we are looking to have more longitudinal data over time to find out what happens with the NAS babies over time. Our Office of National Drug Control Policy, along with the USDA, work together to expand the grants that are available to those who are fighting the chemical dependency and the misuse disorder while they're pregnant, after they've delivered, and of course all throughout their lives. One thing that we've done is work with SAMHSA to make sure that we're connecting these individual men and women, but particularly the moms and their babies, in recovery housing and availing them what I would call the whole person approach, so that we don't just check the box and say, great, here's some temporary housing, but where's the job, where's the skills training, where's the more permanent housing opportunities? Our First Lady, Mrs. Melania Trump, has really led the way in this nation to elevating the awareness of and deepening the engagement and the resources for the neonatal abstinence syndrome babies. As part of the H.R. 6 legislation that passed last year, I'm happy to report to you, with overwhelming bipartisan support, Congresswoman Dingell, I'm sure, is very proud to note that every single Democrat in the House and the Senate, including all those running for president now, voted in favor of H.R. 6, which was the single most comprehensive piece of legislation in our nation's history to tackle the drug crisis at any one time. It ended up being a collection of 50 separate pieces of legislation, all knitted together. And sometimes if you keep adding to legislation, as we all know, you lose support. We actually gain support. And the sum of all of its parts led to this comprehensive piece of legislation. It provides access to treatment. It loosens the regulations on Medicaid being able to provide reimbursement for medication-assisted treatment in facility treatment. It certainly has helped with dislocated worker grants. There's more money there for surveillance, for interdiction of the drugs, for fentanyl detection and analysis and handling. But I really wanted to point out a big feature of it that doesn't get a lot of attention, and it's really terrific. It's called the CRIB Act, and that's an acronym. And essentially, we are providing more resources and attention, really, so that those moms and babies as newborns can stay together. even though the baby has been born chemically dependent and certainly needs those health needs administered to. It's better for the baby, and it sure the heck is better for the mother as well. And so the CRIB Act has provided Medicaid reimbursement for a lot of those health and counseling services. In addition, at a CMS's innovation office, they have the MOM Initiative, which is the Maternal Opioid Misuse Initiative, again, bringing to bear a heightened awareness and probably most importantly, additional resources to allow for this. The President's 2020 budget proposes giving states the authority to allow mothers with substance abuse disorder to stay eligible for Medicaid for 1 year after giving birth. So that's a big increase. In addition to that budget, we call for the projected levels of WIC participants to include, to continue to be served. I expect that you'll continue to have productive conversations today, particularly the health professionals, of which I'm not one, that will be involved in this conversation today. We really want to partner with you to continue to improve the outcomes in our rural communities specifically, but also particularly with respect to maternal health. Your work is very important in helping us also to partner with you so that this whole of government approach truly treats the whole person and doesn't just say, great, check the box, you're doing better, go have a great life with your child, but really keeping pace and keeping in touch with the outcomes much longer after the birth occurs. It now gives me great pleasure to introduce a woman I admire very deeply, and I'm very proud to call friend and partner in this town where bipartisanship is not always appreciated and always approached thusly. Debbie Dingell has been the Congresswoman representing Michigan's 12th Congressional District since 2015, but she is the latest Dingell in what has been decades of service representing that district, the longest serving family, if you will, in Congress, and her husband, the late John Dingell, who was a lion, I would say, in the United States Congress and in Michigan, but really nationwide. Somebody who's been recognized nationwide as a true legislative leader and a true hero on many different causes. He's the longest serving member of Congress. And Debbie Dingell, who's always had a heart for public service, continues in that regard. But she's been doing this for, I guess it's her third term in Congress, third or fourth term, Debbie, in Congress. And I in addition to how often you see her communicating the message and literally going out there day after day on TV, on radio, in print, and making the case of why we need to work together on any number of issues that are affecting our country. In addition to that, I think more fundamentally, it's important to note that Debbie is on the Energy and Commerce, Congresswoman Dingell is on the Energy and Commerce Committee, Natural Resources. She is also on the Health Subcommittee of Energy and Commerce, which is incredibly important for what we're talking about today. She's a senior whip, and she also is one of the members of the House majority who is most active in what I try to do in the White House, which is the nexus of policy and communications. And good policy leads to great communications. You can't flip it around. It doesn't work that way. And I know Congresswoman Dingell lives her life and executes on her public service exactly that way. So it gives me great pleasure to be followed by and to introduce Congresswoman and my friend, Debbie Dingell.
I want to thank Kellyanne for that introduction. We are friends, and we've been friends before both of us got into this life. We've been in policy and communications for a long time, but I don't know that either of us a decade ago thought that either of us would be where we are today, but we are. And we don't agree on everything, but we sure care. We both are women that, on the opioid addiction front, my sister died of a drug overdose. My father was a drug addict. I've spent a lot of time working in this field, and we share that passion and work together. And she loves her kids. Actually, when I'm with her, I'd rather talk to her kids at times than anybody else, which she knows. So I'm glad to be here with her. I want to thank the administrator for including me. the administrator and I have talked. We don't agree on everything, but you know what? A lot of people don't. But if you even agree with yourself from 20 years ago and yourself now, I'd say you got a problem. You know, we got to keep learning and we've got to keep growing. And it's really an honor to be here today with these two and with the director, Cara James, as well, because you're talking about such an important subject. And there isn't anybody in this room that wouldn't be here if we didn't care about what was happening in this country. And if we didn't care what was happening to our babies, what was happening to our infant mortality rate, what was happening to our mothers. I'm not old, but I'm seasoned, and I'm seasoned at this. I chaired I started on this issue in the 80s. I chaired Michigan's Infant Mortality Commission back in the 80s. And, you know, we made a difference then. We actually brought the rates down. And what's terrifying and why it's so important that everybody is here today is the rates are going back up for a variety of reasons. So, you know, despite spending more, and a lot of the points I was going to make have been made by the administrator and Kellyanne, so I'm going to try not to keep repeating the same facts, but I am going to reaffirm why the four of us, the director hasn't spoken yet, but there are 4 women of all kinds of different backgrounds sitting here partnering with you to attack a cause that really needs to be addressed, and I'd like to think ultimately solved. But despite this fact that we're spending more than any other country on hospital-based maternity care, our country has the most pregnancy-related deaths than any developed nation in the country. And we spend more money than anybody else does. We spend almost double than any other industrialized nation, and our health outcomes, period, are not what they should be. So for simply too many Americans, that joy, that excitement of having a baby and some stress associated with your expanding your family ends in tragedy or stressful health situations that should have been avoidable and should have been preventable. And it does, as you both said, happen more often to African American women or women of color, Indians, the Native Americans. The fact is, black women die at a rate of 3 to 4 times higher than white women do during childbirth. And that rate has not improved in 6 decades. 6 decades, 60 years. The quality of the care you receive should not depend on the color of your skin, where you live, or your ability to pay. It's unacceptable and it's unfair. New parents have enough to stress out about. Sleepless nights, adjusting to a new life. But what your ability to get to the doctor, getting care in a rural facility, and socioeconomic stress result in negative outcomes for both the child and the parents. Adequate and proper maternal care ensures children start out life with a healthy and strong beginning. And that's what we all know. We just know too many women can't afford to go to the doctor when they initially become pregnant. They don't get the kind of prenatal care that they don't have the diet. Too many women are taking drugs. They stay on drugs. The interventions that have to happen, or they don't realize the impact of alcohol. They don't understand the impact of smoking. And they're not getting prenatal care. They can't go to the doctor. When I was chair of the Michigan Infant Mortality Task Force, we brought together people from all over the state to develop recommendations for consistent care across the state. We ensured that regional networks were in place to direct early term or at-risk babies to the right hospital and ensured that they got the best possible care. Our largest focus was socially, breaking down the stigmas that prevented women from seeking prenatal and well baby care. And Kellyanne was talking about it. Many women are afraid to say that they have an opioid drug problem. They're afraid of being judged. They're afraid of what somebody's going to say. And a lot of people just simply can't afford the prenatal care. They can't afford the medicine. You know, in Michigan, we actually, and I was trying to get doctors to donate their prenatal care services. We actually got the liability laws changed so that could happen. probably get the trial lawyers after me again, but they weren't happy then. But we've all heard the common phrase, it takes a village. It's cliched, but it's true. Women need to feel comfortable speaking up when something doesn't feel right, and when medical professionals need to trust them. New mothers need to feel comfortable reaching out to their families and friends in their communities for support after the arrival of a child. And we all have a duty to help community members. So we're part of a community. We need to remind people we're part of a community who are adjusting and providing support. And I'll tell you something else we have to address, which we talk about, which is we've got to address our paid leave policies. When women feel pressure to return to work quickly after birth, it leads to worse outcomes. And today, more than a third of our workforce doesn't have a single paid sick day. When taking time off means choosing between a paycheck and taking care of a family member or yourself, nobody wins. So we're going to work together to get this solved. I'm grateful that they both invited me to be part of this. We got to solve it together. That's what I think the message up here is today. You need to tell us what we need to be doing to support you. That's part of it. You know more than we do, but that's what policymakers need to do. We need to hear from people in the field. And here you've got a bipartisan group of people that really care about this issue. And we want to reduce the infant mortality rate in this country. We want to keep moms well, and we want to make sure people are getting the care that they need. Thank you very much.
So good morning. Thank you so much, Administrator Verma and Kellyanne and Representative Dingell. My name is Cara James. I'm the Director of the CMS Office of Minority Health and one of the co-chairs for the CMS Rural Health Council. I want to add my welcome and thank you to all of you for joining us today. We are so pleased that we have quite a packed room here, as well as over 800 people who are joining us virtually. And I think that just highlights how important this issue is. You've already heard a number of the statistics, and we're going to move past those. But one of the other things that I just wanted to add and why we're having our conversation today is really to bring it home to rural communities. And when we think about the changing landscape of rural health care, we've seen more than 100 rural hospitals that have closed since 2010, quite a number of others who've closed their OB departments. It's not just an issue of where women are having to go to deliver, such as Jenny, but as she mentioned, the distance she's having to travel to get to prenatal care, as well as postpartum services and other areas of health care to make sure that they're able to have healthy pregnancies and deliver healthy babies. And this conversation started for us about a year ago as we were on a road trip in North Dakota with our colleagues from the National Rural Health Association and talking about the rising issues and really trying to think about what we could do. And so today we want to have a conversation, and I emphasize a conversation because as you've heard from each of the speakers, we don't have the answers for all of this and we really do need to hear from you. So one of the things that we want to do, if we go to the next slide, is I want to start by just thanking all of the people who helped bring this day together for us. So we have quite a number of partners, as you can see, the American Academy of Family Physicians, American College of Obstetricians and Gynecologists, our colleagues at CDC, as well as the Office of Women's Health and HRSA, Mama's Voices, who brought you the story of Jenny and her, and also I want to just acknowledge Dr. McKay, who, I just lost her, there she is, for thanking you for all the work that you're doing and for helping us to tell the story, to really put the patient first, because it really is about the women and their families and their babies that we're trying to help. We also have partnerships with the National Birth Equity Collaborative, and last but not least, our friends and colleagues at the National Rural Health Association, all of whom came together to help organize the day that we have. So let's dive into that day. Again, this is a conversation, so we want all of you to join us in the conversation. For those of you who are participating virtually, please use the chat box or email us, share your ideas and your thoughts. For each of you, you have received, if you registered, a worksheet where we are going to put you to work. So this is all about how do we build a path forward, and that's what we're going to be doing at the end of the day after we've heard through from a number of the speakers around framing the issue, talking about some of the interesting models of care that are being delivered and some of the issues that we're seeing, and then moving into some of our policy thoughts. And then we want to close out the day really from hearing from all of you and what your thoughts are. So as you're hearing this conversations and discussion that's happening this morning, please take notes. You're going to see some poster boards that are going to be outside where we want you to add your ideas and thoughts, because at the end of the day, this really is both the start of a conversation, but it is the beginning of a journey for us to really figure out how do we improve access to maternal health care in rural communities and health outcomes for our women and reduce disparities. You can also join us on Twitter with our hashtag Rural Moms and Rethinking Rural Health. So with that, I'm going to dive in and introduce our first panelist and moderator, I should say, for our first panel. We have asked them, we're going to keep them on time so we can get everybody out of here before rush hour gets too terrible, but we want you really to stay for the full day. So with that, I'm really pleased to invite up the panelists, and while I'm doing that, I'm going to introduce the moderator for this session, which is Dr. Katie Cosmanaho, who is the Associate Professor in the Division of Health Policy and Management at the University of Minnesota School of Public Health. Dr. Cosmanaho conducts research to inform the development, implementation, and evaluation of health policy, the impacts of healthcare delivery, quality, and outcomes during critical times of the life course, including pregnancy and childbirth. And it's a great colleague, so thank you so much for joining us, and let's get started.